let's just close with the question of pros and cons of CAR-T, antibody-drug conjugates, and BiTEs. Let's assume that these are probably going to move earlier in treatment into sort of early relapse settings. Why would you choose one over the other? Maybe I'll give Natalie a chance to speak here.
Well, I think everybody here probably has the same thoughts, is that, as these agents get moved up earlier, I think we're all very interested to see some of the earlier data like KarMMa-3, when you are offering CAR-T, after only a couple of therapies. If you start seeing patients then have durable responses for years, I think that's going to be fairly persuasive. I think the question is whether we'll be able to do one sequential BCMA therapy after another, and then what sequence should you do this in?
Yeah, so we're going to ignore cost right now because, of course, this is not cheap. Nupur, what do you think? Where are we going to use these?
So I do think they're all going to move earlier and earlier. And some of the things we talked about in terms of disadvantages of it taking 4 to 6 weeks to produce, etc., are going to go away. And we are going to be able to do it earlier on without having to worry about things like the bridging therapy. I do think we have to think about sequencing some of these BCMA targets, because one of the good things about CAR T cells, it's one and done right now. And if we are able to see a durability of response, that's going to, so in my mind, that's going to be a huge benefit for our patients. If, on the other hand, as we bring them earlier, we don't see a remission duration, which is long lasting, and we've got to pull back with some of these other agents, then it's an open area. And we will be talking about sequencing some of these BCMA targeted approaches.
Tom, if you had a patient today who was, 3 or 4 prior therapies, and if all 3 were available, would you have a preference for antibody-drug conjugate over a BiTE? We'll take CAR-T out of the equation for now.
I actually think that the bispecific antibodies are going to be extremely potent for all these patients. And it's going to be moved to frontline in early relapse quite quickly. I mean, these response rates are 80, 90%. It's amazing, actually. So I would prefer that bispecific. Okay,
last word to Peter Verhees.
So I would agree with Tom in general. I think for like a triple class refractory patient, if I had the choice between an ADC and a bispecific, BCMA targeted, I would lean towards the bispecific. If I had a patient with significant cardiopulmonary disease who I was concerned may not tolerate cytokine release syndrome, I might gravitate towards the antibody-drug conjugate in that particular scenario. But otherwise, the majority of the patients would get the bispecific antibodies. And I have a similar level of enthusiasm as Tom does. I think if the response rates, and to your point, the durability of those responses are even similar to what we're seeing with CAR T cells, that's a game changer. Although Nupur's right, patients enjoy that treatment-free interval. I think that that's one of the most valuable things for them after going through CAR T cell therapy.
Well, thank you, everybody. Well, there you have it, folks. Everybody's very excited about BCMA-targeted therapy. We have numerous, probably over a dozen agents in the clinic right now being studied that will probably transform how we treat myeloma, but lots to learn and lots of work to be done to figure out where we're going to use them most effectively and most cost effectively as well. So I want to thank the panelists for their time today. I think it's been a great discussion, and we've covered a lot of ground quite quickly. So with that, I'd like to thank you all for this, Dr. Callender, Dr. Martin, Dr. Raj, and Dr. Verhees, and thank you again to our viewing audience. We hope you found this ONC Live peer exchange discussion to be useful and informative.